But the thing is, when was the last time you had a scalp biopsy? And, given how kind of invasive, it's minimally invasive, but you can't just always get a scalp biopsy if you feel like you're shedding hair. But seriously, when was the last time you even got one? Just one, which is really all you need. Because most examinations that I've seen, especially when talking to doctors, are done visually, where they just look at your scalp and then they refer to a checklist. Sometimes they use a dermatoscope to check for any obvious signs of inflammation, which is, I'll say maybe kind of useful. While this approach works for the majority of cases, as most hair loss is due to maybe DHT, being the condition of androgenetic alopecia, the literature on biopsies for conditions like, let's say, I don't know, Lichen Planopilaris or LPP, shows that it tends to be diagnosed mostly in postmenopausal women. So wait, where am I going with this? Why am I bringing up postmenopausal women? Doesn't that just mean that Lichen Planopilaris, LPP, this sort of condition that I'm talking about, just affects them? Why do we have to be, so generalistic? Well, we have to look at the literature to see what's actually going on here and why it's kind of misleading. According to Kania-Lepe et al., in the research paper titled, quote, Lichen Planopilaris, unquote, by the Stats Pearl publication, the incidence of cicatricial alopecias, being scarring alopecias, is not precisely known. Lichen planopilaris is reported as the most frequent primary scarring alopecia or cicatricial alopecia. That's what, scarring or cicatricial, those two terms can be interchangeable. It accounts for 43% of cases when it comes to scarring alopecias. And they looked at a specific study that involves around 72 patients. And that's where they made that 43% determination. This condition typically affects women, according to them, right, between the ages of 40 to 60, more than men. Up to 50% of patients may develop characteristics of lichen planus lesions. This is another condition that's related to lichenoid tissue or lichen planopilaris. And these lesions affect the skin, mucosal membranes, and even the nails. So sometimes you might see somebody who has lichen planopilaris on their scalp. They might have a defect in their toenails or fingernails. This is also seen in conditions like alopecia areata, where you'll see the patchy hair loss, but you'll also see that sort of issue being presented in the fingernails as well. Why? Because the hair and the fingernails are made out of the same structure. This structure would be the protein called keratin, and this is produced from cells called keratinocytes. So returning back to this sort of article by Kania-Lepe et al., the authors emphasize the importance of understanding the autoimmune nature of lichen planopilaris and its impacts on patient care. However, is it truly the case? Is this paper really actually coming up with a reasonable sort of portrayalment of lichen planopilaris? Is lichen planopilaris primarily a condition affecting postmenopausal women, or is there a strong bias against performing biopsies in men in order to elucidate if that's actually the case, right? Because when a balding dude walks into a clinic, it's often assumed that he has the typical androgenetic alopecia case. From my observations, a dermatologist might prescribe finasteride or dutasteride, recommend platelet-rich plasma PRP treatments, and perhaps order some blood work. Maybe. That's probably the most they might even do. And then from there, a diagnosis of androgenetic alopecia is typically given, without a biopsy. In contrast, hair loss in women tends to raise alarms among physicians. Even if it's related to androgenetic alopecia, and with our current statistics, it tends to be, that's the case, that women, if they ever are to have hair loss, it might be just androgenetic alopecia. Conditions like polycystic ovarian syndrome, or PCOS, or menopausal changes prompt doctors to become more involved in diagnosing or figuring out if there's any sort of underlying conditions, right? Because the hair loss might present itself after an underlying condition. So again, this would make the doctor want to investigate more and likely, do a scalp biopsy to see what's going on here. And this is more or less confirmed as a standard practice from a study titled, quote, Evaluation and Treatment of Male and Female Pattern Hair Loss, unquote, by Olsen et al. 2005, which states, again, quote, diagnosis in men usually does not require a biopsy unless atypical patterns, such as diffuse or female pattern hair loss, or scalp changes indicative of cicatricial alopecia, complicate the case. In women, however, biopsies are more commonly performed to exclude chronic telogen effluvium, diffuse alopecia areata, or early cicatricial alopecia, unquote. Now, this creates a selection bias in the data. Men aren't biopsied as frequently as postmenopausal women. Now, granted, this paper is from 2005. However, the practices are more or less the same today, where biopsies are typically reserved for more obvious and severe cases where clinical signs, quite frankly, would clearly warrant further investigation. So, essentially, what I'm trying to say is the problem is so bad, at that point, they're just trying to see what specific scarring alopecia that you have, not whether or not you're actually having earlier stages of it. So, if we think about androgenetic alopecia treatment, what's the motto, right? Early treatment saves more hairs. So I don't think it would make sense to wait for, to have visible signs of, large scales of inflammation, missing ostas or follicular openings, having that perifollicular inflammation, smooth discolored skin, and other more pronounced indicators. I don't think it would be useful to wait for things to get that bad when it would be more prudent to do the biopsies in its earlier stages when the scarring alopecia isn't that severe. So again, to reiterate, that kind of approach where you wait until things to get really bad and, the clinical signs are clearly obvious, this often misses opportunities to catch early signs of scarring or autoimmune alopecias, which could lead to irreversible damage if not identified and treated promptly. Because look, it's also the fact that even when you identify that you have a specific scarring alopecia, let's say Lichen Planopilaris, now you have to find out what treatments will work for you, right? Are you going to take a PPAR-GAMMA agonist like pioglitazone? Do you have to use, in conjunction with that, corticosteroids like clobetasol propionate? Maybe you would have to use calcipotriol to also aid in the de-inflammation process. Even with the thing that I mentioned before, the pioglitazone, the PPAR-GAMMA agonist, you might have to titrate the dose from 15 milligrams up to 50 milligrams because there are some studies that show it being effective at particular doses. And this probably matches with the severity of the cicatricial or scarring alopecia, the Lichen planopilaris, because from what we can see in the literature, it seems to be that when there's a defect with the PPAR-GAMMA receptor, this leads to an inability to metabolize lipids in the tissue, and that ultimately results in what? Scarring, because the immune system tries to come in there and destroy the things that are creating those lipids, right? When you have a large amount of lipids in tissue, you get this thing called lipotoxicity, and that initiates the cascade of the immune system coming in and all these horrible secondary and tertiary pro-inflammatory conditions. And this would include the destruction of hair follicles, sebaceous glands, and even the stem cell bulge, where actually you need this structure in order to grow hair. If the stem cell bulge is destroyed, then you no longer have the ability for that follicle, that is, to grow hair. That's just how it is. So really much hasn't changed 20 years later. As of writing this script of this video and recording it, it is January 10th, 2025. So the last study that we looked at from Olsen et al. 2005 was literally written 20 years ago. So when we look at the academic research compilation book by Mohammed Ahmed titled, quote, Alopecia, unquote, published in 2018, it highlights these sort of similar trends, right? Ahmed emphasizes the selective use of scalp biopsies, noting that while they are critical diagnostic tools, they are often underutilized unless the clinical presentation is ambiguous or severe. And this sort of underscores a gap in the current practices where early detection, like I said before, particularly in scarring alopecias, like Lichen planopilaris or central centrifugal cicatricial alopecia or CCCA, is not always prioritized. So we really need to take care of these practices and revisit them. And this creates a selection bias in the data, like I mentioned earlier. Because men aren't biopsied as frequently as women, or even postmenopausal women, obviously you're going to have the data suggesting that, Lichen planopilaris only affects postmenopausal women. And again, this practice might be underutilized in women with slow progressing hair loss conditions, like a gradual progression of Lichen planopilaris that destroys follicles, let's say, over years. And these women might be excluded from biopsy data for a considerable amount of time, right? So again, we have this selection bias in the data. Men aren't biopsied as frequently as postmenopausal women. Additionally, other women who aren't postmenopausal aren't biopsied as frequently. It's only when they get really, really bad, when things realistically can't be reversed that much, that's when they finally, get that biopsy. The point I'm trying to make here is that scalp biopsies should be more common for everyone than they currently are. I'm not saying that everyone should, go in and get their scalp cut out a bit, but I'm saying it has to be a bit more common. Because not only would it help people who have early signs of scarring alopecias, but also it would inform the literature better to give an accurate representation of what's actually going on. We would get actual numbers rather than numbers that are kind of suspect. Now, I talked to Dr. William Rassman, the inventor of the FUE hair transplant procedure, on my podcast, Hair Stacks. During our conversation, Dr. Rassman mentioned that some of his colleagues at the Bernstein Medical Center for Hair Loss Restoration make it a standard practice to biopsy anyone who's potentially seeking a hair transplant. This is done to rule out other potential causes of hair loss besides androgenetic alopecia. Why? Because, well, if you have Lichen Planopilaris or another scarring alopecia, over time, the place where you're transplanting the hair to, the site of the condition, those follicles are very, very likely to die in about 1 to maybe 5 years. As a side note, this could possibly be why some hair transplants actually fail. Maybe these people don't have androgenetic alopecia. Even if they're on treatment, they could be dealing with an autoimmune related condition, which, let's be real, DHT drugs or anti-DHT drugs like 5-alpha-reductase inhibitors or topical anti-androgens aren't really going to do that much to mitigate. Anyway, Dr. Rassman explained that through this more rigorous analysis, both he in his own practice as well as Dr. Shaver and staff at the Bernstein Medical Center have identified comorbid conditions of hair loss, such as androgenetic alopecia overlapping with Lichen Planopilaris and even other issues. While there aren't many studies on this topic, some research indicates that women are more thoroughly investigated for their hair loss concerns than men, and we'll look at the statistics regarding that. But right now, I'm going to actually play a clip on the screen where Dr. Rassman kind of talks about this. From some research I've done by looking at the literature, like the early Norwood scales, as well as what we know in recent years about cell lineage differentiation, where DHT-sensitive hairs have different characteristics than more resistant ones, the idea that the type of hair loss pattern in androgenetic alopecia is likely a genetic feature in and of itself, like, say, someone's height or eye color seems to be very reasonable, and some features are more common than others. But in DUPA, it appears to be an aesthetic of sorts. I say this because all it looks like is a diffuse, unpatterned hair loss. There are many conditions like hyperprolactinemia, hypothyroidism, and even some forms of areata, like alopecia areata incognita, that can manifest a DUPA-like condition, aside from androgenetic alopecia. That being said, have you ever recommended scalp biopsies in your practice when it comes to more atypical patterns of hair loss?
Yes, Dr. Robert Bernstein and Dr. Christine Shaver in New York. Dr. Shaver she's a dermatologist, and she had a particular interest in something called Lichen Planopilaris, which is another disease of the scalp that causes hair loss. There are a series of diseases of the scalp that cause hair loss, and you don't want to do surgery, hair transplant, on people that have fronting fibrosing alopecia or Lichen Planopilaris or a variety of these other scarring alopecias. So she has made a habit of starting to biopsy young men in 2 places when she has even a suspicion that there might be some underlying disease, even though it doesn't show very well. And she has found an enormous number of patients have Lichen Planopilaris, which means that these people, if they had a hair transplant, will fail. Eventually, sooner or later, will lose their hair. So when we look at, I look at my career now 34 years in the hair transplant business, and I used to see every once in a while a patient would come in 10 years out, 7 years out. I even remember somebody 3 years out that came to me and he had a beautiful head of hair after the surgery. And then all of a sudden the hair started to fall out. And I always sort of think of the hair around the side and back as permanent. It never went away. But at that time, I didn't understand that these people probably had Lichen Planopilaris and had this autoimmune disease in the scalp. And it was just inactive. And then as they got older, it became active. We find these diseases far more common in women than men. And for that reason, because they're so common in women, the doctors haven't thought of this as a male disease. And yet it is a male disease. And Dr. Saber is basically writing this up now for publication. So I think that this is an important observation. And so to answer the question, you make bad diagnosis.
I see.
I think if I'm suspicious of something, I'll biopsy it.
From what I see on websites like Reddit, people often suspect that they may not only have androgenic alopecia, and because not everyone is getting a biopsy, it could be the case that issues like Lichen Planopilaris and other conditions are often overlooked.
The problem in the hair transplant industry, and I don't mean to be too accusatory, but there are many doctors that enter this business that just learn how to do FUE and they don't learn dermatology of the scalp. And if they don't learn dermatology of the scalp and the diseases of the scalp, then they're going to not recognize these diseases, and then they're going to transplant these people as they develop balding, and then they're going to fail maybe 3 or 5 years later.
Yeah.
And when they failed in my hands down the road, and this, by the way, in my practice, the numbers that would fail were about 3% that would fail out there in 5, 10, 15 years later. But I'm sure that those 3% were Lichen Planopilaris and a diagnosis that was never made. And by the way, nobody knew about it then. It wasn't like I was just a bad doctor. Nobody had talked about it. It was never considered a disease of men. And sure as hell it is.
So, my interview with Dr. William Raspin shows that it isn't a common practice to biopsy men. In fact, Dr. Jeff Donovan, possibly one of the leading hair loss specialists in the world, dermatologist, just all around great doctor. In his article about scarring alopecias, particularly Lichen Planopilaris, Dr. Donovan states that, quote, one needs to take into account the patient's entire story. If a physician just biopsy every patient that comes into the office, I can guarantee one will make a whole lot more diagnoses of LPP, Lichen Planopilaris, than truly are present. I'm a big believer in this, even though LPP is underdiagnosed in the world. But listening to the patient's entire story and examining the scalp and reviewing what the biopsy shows, not just the final readout on the bottom line, one can usually get a fairly good sense. However, in rare cases, time is the best judge, as a missed case of LPP will likely declare itself over time. Unquote. You see, and that is the idea. If more scalp biopsies are done, Dr. Donovan and even Dr. William Raspin, these, to use clinical trial terms, key opinion influencers, where they have a wealth of knowledge, they've done a lot to actually contradict the literature and shows where the literature is actually lacking. They point at, something significant, right? This lack of biopsies. But if we do more biopsies, you're more likely to find that the rates in your particular clinic for conditions like Lichen Planopilaris, frontal fibrosing alopecia, and other scarring alopecias are probably higher than what is represented in the medical literature. In fact, we can refer to a study titled, quote, Frequency of the Types of Alopecia at 22 Specialist Hair Clinics, a Multi-Center Study, unquote, by Vanyo Galvin et al. This retrospective study analyzed previously recorded data, hence the term retrospective, for multiple centers worldwide, covering continents such as Europe, the Americas, Africa, and Australia. This study included a total of 2,835 patients, with 72.7% being female and 27.3% being male, and a reported 3,133 diagnoses of alopecia, with 73% being non-scarring types of alopecia and 27% being scarring alopecias. So a total of 57 different alopecia types were identified. That's a lot. I didn't even know we had 57. Anyway, maybe there were like unique variations here and there, but anyway, the most frequent type was androgenetic alopecia, coming in at 37.7%, followed by alopecia areata at 18.2%, telogen effluvium, which isn't an alopecia, but still it'll be included as a hair loss disorder, being 11.3%, frontal fibrosing alopecia being 10.8%. That's a bit high compared to telogen effluvium, by the way. In any case, moving on from that, Lichen Planopilaris being 7.6%, Folliculitis decalvans being 2.8%. And for those of you who don't know, folliculitis decalvans is when you have a bacterial infection in your hair follicle, which actually causes a scarring alopecia, which can destroy the follicle outright. Next, discoid lupus being at 1.9%. And then finally, fibrosing alopecia in a pattern distribution being at 1.8%. Now, if we are to break down these scarring alopecia conditions by gender, we can get an idea of what's going on here. So, in total, scarring alopecias accounted for 27% of all alopecia cases in this dataset. Among the specified conditions studied included 1. Frontal fibrosing alopecia, and of the 337 total cases, 320 or 95% occurred in women, and 17 or 5% occurred in men. For the condition, also a scarring alopecia called central centrifugal cicatricial alopecia, say that 3 times fast, of the 30 cases, 29 or 97% were in women, and 1 or 3% was a man. For Lichen Planopilaris, of the 239 total cases, 198 or 83% affected women, and 41 or 17% affected men. For fibrosing alopecia in a pattern distribution, of the 57 cases, 51 or 89% occurred in women, and 6 or 11% occurred in men. So, given that frontal fibrosing alopecia, central centrifugal cicatricial alopecia, Lichen planopilaris, and fibrosing alopecia in a pattern distribution are increasingly recognized as clinical variants of Lichen planopilaris based on shared histological features observed upon biopsy, these conditions can be combined into one broader category. So when we look at all of the alopecia cases and we combined all of the scarring alopecias into one merged condition, right? Let's just call it broader Lichen planopilaris variants. In that data set, we can see that there are 663 cases of scarring alopecia, and of these, 598 cases, or 90.2%, occurred in women, while 65 cases, or 9.8%, occurred in men. This combined perspective highlights the significant predominance of scarring alopecias in women, but also underscores the presence of these conditions in men too, albeit at a lower frequency. The proportions of Lichen planopilaris and its clinical variants is strikingly high in this study, again with 663 cases representing a significant portion of all alopecias diagnosed. However, it is important to note here that this is only a retrospective study and does not clarify whether all cases were biopsy confirmed. So this sort of limitation is critical because many individuals may have co-occurring alopecia conditions, such as androgenetic alopecia alongside with latent or subclinical scarring alopecias that remain undiagnosed without histological confirmations. But I will say that there likely was a bit of an overlap here too. Maybe there were some biopsies that occurred because you have around 2,000 patients, but then at the same time you have 3,100 diagnoses. So that suggests that some of the patients probably were noted to have more than one condition, but it could very well still be higher. Again, another point we can see here again is this gender bias in biopsy practices. So I don't really see this study actually getting away from the fact that there could be gender bias when it comes to looking at certain hair loss conditions, right? They're just going to biopsy women more because, when a woman comes to a clinic having hair loss, it prompts further investigation, right? Where for a man, they probably have to have some serious sort of, conditions going on. In fact, we don't even have to speculate here because it actually mentions in the study itself that 298 patients, or 10.5%, presented with two types of alopecias at the same time. So that's pretty significant here. But it could still be underpowered. But once again, this isn't beneficial for anyone. So we should adopt more minimally invasive practices like biopsies, right? Or even the KOH test, where they come in, they scrape a bit of your skin, and they examine it. A microbiologist examines to see if there's any features of like yeast or fungus that could be contributing to conditions like folliculitis decalvans, or maybe even tinea capitis, or, more commonly referred to as ringworm, right? These are some tests you can do. Scalp biopsy, and a KOH test. I think these tools are very important if you're not getting any sort of progress while on dutasteride or finasteride, especially dutasteride, because that thing wipes out a lot of scalp DHT. So if you're still getting worse, it might be the case highly, at least for you, it might highly be the case that you're dealing with another condition alongside androgenetic alopecia. So consider those two things: scalp biopsy and a KOH test. But we're not done here yet. Let's look at how, biased the literature is to kind of show you guys what's going on here. So in the study titled, quote, Lichen Planopilaris in Women, a retrospective review of 232 women seen at Mayo Clinic from 1992 to 2016, unquote, by Sidney C. Larkin et al., published in 2020. Here, researchers provided detailed insights into the prevalence and characteristics of lichen planopilaris among women. The study found that out of the 232 women diagnosed with lichen planopilaris, an overwhelming 92.7% presented with hair loss, highlighting the commonality of this symptom in lichen planopilaris patients. Furthermore, this study reported that 217 of these women underwent confirmatory biopsies, so it reinforces the importance of biopsies in diagnosing lichen planopilaris. The study also notes that lichen planopilaris predominantly affects women, with a mean age diagnosis of 59.8 years. And that's kind of a weird thing to say because this is a study that's exclusively looking at women, so of course they're going to say that it predominantly affects women. This is kind of like me foreshadowing what actually went on here and why this seems kind of like a weird study. So there was an inclusion of a large number of women who were biopsied, and this shows through their diagnostic approach that, typically is taken for female patients experiencing hair loss. So typically women who are experiencing hair loss, once again, I will explain this over and over again, they will get biopsied more than men. But then the authors state something that was kind of strange. They said this, quote, men were excluded from this study to more accurately determine the association of hormonal factors in lichen planopilaris pathogenesis, unquote. Now, this exclusion removes us from knowing the possibilities of, any potential histopathological differences that lichen planopilaris could have, maybe it could have, in males, or even hormonal factors that could possibly exist beyond DHT. What I'm trying to say is, why did they exclude men from this study? Like, okay, I get it. Yeah, they wanted to see how it was in women, but their premise seemed as if they kind of came to the conclusion already to determine that, well, this condition already affects women, so we're just trying to see, what factors are actually influencing this. But how can they just come out from the get-go by just saying, well, this condition already affects women or solely seems to affect women, so let's exclude men from this research? It's kind of weird. And more importantly, I'm also concerned about the findings that were, discovered in this study. And essentially, it stated that women, or let's just say people in this case, if we're assuming that, men who weren't represented otherwise would have had lichen planopilaris, so people who tended to have lichen planopilaris, they were also comorbid with other conditions like diabetes, skin cancer, nutritional deficiencies, and much more. So by excluding the men in the dataset and not having a more robust and rigorous investigation leaves out a lot of people, including, as I've previously mentioned, women who may not be menopausal or postmenopausal, but have a slow progressing scarring alopecia condition like lichen planopilaris, maybe subclinical levels of lichen planopilaris, where you can see the early signs of it, but it's not necessarily fully destroying structures yet. It's still a problem nonetheless, and it should still be addressed while it's still manageable, because once those hair follicles are destroyed, it's going to be, a lot to bring them back, and most of the time they don't come back, especially if the damage has gone on for like decades. Now, let's go in deeper into the literature to understand the nature of the underreporting. In September 2022, a cross-sectional study titled, quote, Prevalence of Lichen Planopilaris in the United States, a cross-sectional study of the All of Us research program, unquote, authored by Tejas P. Joshi et al., and it was published in the Journal of the American Academy of Dermatology International. This study aimed to estimate the prevalence of lichen planopilaris across a diverse nationwide sample of U.S. patients. So out of 327,654 people in this database, only 142 were identified as having lichen planopilaris, representing an overall prevalence of 0.043%, with a confidence interval of 95%, of the range, of this percentage being between 0.042% to 0.044%. The study found that 91.6% of the lichen planopilaris patients were, surprise, surprise, female, and members of the white Caucasian race, and they had the highest prevalence, right, of this particular condition. The average age of diagnosis was 62.4 years. Now, once again, we have a very questionable study that is, weirdly done. So you mean to tell me, out of the 327,654 people with hair loss in this database, only 142 had lichen planopilaris? Let me ask you a question. How was this determined? Did every person in this study, in this database, have their hair loss condition confirmed through biopsy in this retrospective dataset? I'm particularly concerned here because if this wasn't the case, then most of the subjects in this dataset were not confirmed through biopsy, but rather through a clinical assessment where the physician simply looked with their eyes or perhaps used a dermatoscope to examine subjects and their scalp, and we may be facing a significant bias in the literature. I believe this bias is further emphasized when researchers ignore data to fit preconceived notions, as we saw in the case from that one Mayo Clinic study, where they were essentially coming from the standpoint that lichen planopilaris already affects women, so let's just throw out the male data. Again, this was seen in that Mayo Clinic paper titled, quote, Lichen planopilaris in Women, a retrospective review of 232 women seen at the Mayo Clinic from 1992 to 2016, unquote, authored by Sidney C. Larkin et al. So this is the huge gap in the literature, and this is probably why a lot of people are having issues with identifying, what their DUPA or diffuse and pattern alopecia condition is, or what their retrograde alopecia condition is, right? Like I did with the example in the beginning of the video. Imagine patient A and patient B, they're both missing their right hands, right? Patient A, it seems like they just got it amputated. Patient B, if I recall correctly, I think it was patient B, they were born with a sort of congenital defect that caused their right hand to be missing, that being phocomelia. So let's apply that logic here, right? When you get a scalp biopsy and even a KOH test, when you have DUPA or retrograde alopecia, what you're essentially trying to do is you're trying to find out if, is my hair loss due to androgenetic alopecia? Does it have the histopathological features of an androgenetic alopecia biopsy? Or does my hair loss have to do with, I don't know, maybe lichen planopilaris, right? Does my DUPA have to do with lichen planopilaris?